interacting with us. तो दूसरी बात ये है कि what can we do to engage more with you in the sense जैसे आज सेशन किया ऐसे मतलब periodically conference करें, शाम को करें, which may be easier for you. Because तो दिन का टाइम सबका प्रैक्टिस का ही होता है और अब तो नोएडा भी 10 महीने में जाना चाहिए. हाँ, तो वो extended ही रहेगा. So how many of you are from across the river?
47.
40 people from across from Noida area. Wow, okay. तो वो तो बहुत अच्छा है. So नोएडा आपको दिखता है सेक्टर 50 कभी?
Yes, sir. दिखना मैदान में दिखाई दे रहा है. पूरे रोड पर कंस्ट्रक्शन.
चलो आप लोगों का वहाँ साथ रहेगा तो और भी अच्छा होगा. अच्छा, दूसरा ये था कि एनी पर्टिकुलर एरिया, चाहे यहाँ पे चाहे वहाँ नोएडा की एसोसिएशन कुछ है या जो भी है, जिसमें हम शेयर कर सकें नॉलेज, न्यू फ्रंटियर्स क्या है, कैसा है, ये भी आप लोग बताएं, तो वी कैन ट्राई टू कनेक्ट.
सर आज भी हमारी 2 एसोसिएशन इसमें इन्वॉल्व है. एक तो नीमा है, नेशनल इंटीग्रेटेड मेडिकल एसोसिएशन, जो ऑल ओवर इंडिया लेवल पे है.
अच्छा.
नोएडा की अपनी अलग ब्रांच है. नोएडा के जितने भी डॉक्टर्स हैं वो नीमा से ही रिलेटेड आए हैं. और एक जो दिल्ली में आईसीएम डॉक्टर्स हैं, जिसमें ऑल ओवर दिल्ली में 1000 डॉक्टर्स हैं. नीमा में तो 1000 से भी ज़्यादा डॉक्टर्स हैं जो ऑल ओवर इंडिया है.
अच्छा.
नोएडा की ब्रांच अलग है, तो हम चाहेंगे आप नीमा नोएडा के साथ करें. फर्स्ट मीटिंग हमारी नीमा नोएडा की हो मैदान पर.
हाँ नहीं, बिल्कुल बिल्कुल करेंगे. यही तो मैं बोल रहा हूँ कि ये आइडिया ये था कि क्या चीज़ें हैं जिसके अंदर इस जो देखो आप लोगों ने ट्रस्ट दिखाया, we are one, hopefully we are living up to that trust. दूसरा, we want to respect all of you people to say what can we do to do for your health and stuff like that. And third thing is what can we do generally for the public together.
Awareness, sir. Awareness. We should do awareness.
हाँ.
Basically.
तो ये जैसे ये है BLS, जो आई थिंक आप लोगों ने आज डेमोन्स्ट्रेट किया है, तो वो कम्युनिटी में भी जा सकता है.
यस.
अवेयरनेस, तो ये अवेयरनेस टॉक्स, ऐसे कैंप्स, वी विल सेंड द टीम्स एंड ऑल दैट.
आरडब्ल्यू लेवल पर कर सकते हैं सर.
हाँ जी,
सेक्टर्स जो आरडब्ल्यू होती है, रेजिडेंट वेलफेयर,
बिल्कुल कर सकते हैं.
वहाँ पर कम्युनिटी सेंटर्स होते हैं, उसमें भी आप उसकी फैमिली के साथ जुड़ सकते हैं BLS करके.
ठीक है, तो आप एक्सप्लोर करो. ये गाँव में तो कर रहे हैं
जी,
पर नोएडा का नहीं सोचा था कि आपने
नोएडा में इसके साथ काफ़ी कर चुके हैं BLS का. तो हम तो चाहेंगे आपके साथ भी करें.
नहीं, वो तो है ना कि वो बाकी तो सब बेस्ट है, ये जो बेस्ट के साथ करना है तो वो
बेस्ट के साथ ही करेंगे.
You will be glad to know that for 5th year in a row, Newsweek International 28 countries का सर्वे करती है. तो 5th year in a row we have been named as the best private hospital in India. And within the first 150 hospitals of the world. तो इसलिए मतलब कुछ तो है standard and we try to maintain it. But more importantly, it is the humanity that we want to spread. कि सबसे मतलब जो कनेक्शन पब्लिक से हो, पेशेंट के साथ हो, आप लोगों के साथ स्पेशली हो, तो वो that is like a family relationship, so that we can contribute to each other in whatever way. So I will leave you in the good hands of Dr. Gaurav Goyal was about to, and thank you for making the time. But आप मेरा नंबर शेयर करने का सब कभी भी कोई प्रॉब्लम हो, कुछ हो, तो यू वांट टू गेट इन टच विद मी, प्लीज डू. ठीक है ना? ओके सर.
Thank you so much.
थैंक यू.
सर के साथ एक फोटो तो जाए सर प्लीज.
आजकल तो
अब सेकंड ग्रुप हो जाए। सर प्लीज एक सेकंड। कहाँ ले
भैया जिसका हो गया है वो तो आ जाएं।
सर आप नीचे प्लीज जिनका हो गया आप आ
Respected doctors, I am humbly requesting to please maintain the decorum. Respected doctors,
प्लीज आप पीछे हो जाइए। रिक्वेस्ट सर
please respected doctors,
सर प्लीज थोड़ा साइड आप चलिए। सर आप एक्सक्यूज मी सर प्लीज साइड हो जाइए। सर प्लीज सर आ जाओ। सर आइए।
निकिता
दोस्तों ये हैं चेयरमैन मेदांता हॉस्पिटल माने हुए इंडिया के कार्डियोलॉजिस्ट पद्म श्री पद्म भूषण। भाई मैं फोटो अपना नहीं कर पाऊंगा।
सर आ जाइए प्लीज साइड हो जाइए। प्लीज सर आ सर प्लीज साइड प्लीज
थैंक यू सर। हमारे तो हमारा तो फोटो ही ना खींचा। ये मुझे ही भाई हैं हमारे लगे हुए हैं। किससे मिले अभी आप?
डॉक्टर खान साहब से।
अच्छा क्या है वो?
कार्डियोलॉजिस्ट हैं।
और
क्या बताया?
मेदांता के चेयरमैन हैं।
मेदांता के चेयरमैन हैं। जी जी। लेट आए नासिर
हम हाँ जी जलवे में खा
हमारे पास ठीक है था कहाँ से क्या लगता है। हाँ
ऐसे पकड़ के रखो बस आप।
हाँ बस भाई साहब नाज़िर भाई वो भी क्या सिखाना है।
ऐसे पकड़ के रखना।
हाँ वो भी सिखाना है। नहीं अभी इनको मीडिया इंचार्ज ही नहीं बनवाऊंगा। दो फायदे हैं इसमें, आईएसएम का भी काम होगा, इनका भी चैनल पे थोड़ा सा प्रमोशन होगा। आईएसएम
ये बता दी भाई साहब, नुस्खा ना डाला करें इसमें।
नुस्खे बड़े डालते हुए टेढ़े का इलाज।
भैया अगर किसी का टेढ़ा हो गया हो तो सीधा करवाना हो तो बता देना। हमारे पास बहुत सारा, हमारे चैनल पर बहुत सारी चीज़ें पड़ी हुई हैं जिनका आप इस्तेमाल करके जो है सीधा कर सकते हैं अगर टेढ़ा हो गया है तो।
डायरेक्टली लिखा हुआ।
और किसी को जो है ना न्यूरोपैथी हो गई हो डायबिटीज़ की वजह से तो चैनल पर देख लें।
डायबिटीज तो नहीं है, वैसे न्यूरोपैथी हो गई हमें तो।
नाज़िर भाई लोग ना आपने उसमें ना कमेंट करके डाला करें, तो आपसे ही पूछा करें।
देखो दोस्तों, अगर आपने चैनल को देखा है तो कमेंट ज़रूर कीजिए। वीडियो आप ये लाइव स्ट्रीमिंग हो रही है, अगर आप लोग भी देखना चाहें अपने वीडियोस को तो डॉक्टर नासिर खान 99 पर आप विज़िट कर सकते हैं। और यहाँ पर दिल्ली एनसीआर की बहुत महानुभाव हस्तियाँ आई हुई हैं और सारे मेडिकल प्रोफेशन से ही रिलेटेड हैं, सभी लोग डॉक्टर हैं। और मेदांता हॉस्पिटल में हैं हम लोग, लाइव सेशन है, आप देख सकते हैं। अभी जो है डॉक्टर तेहरान साहब आए थे, लेकिन देखो मैंने फ़ोटो नहीं खिंचवाया आप लोगों की वजह से। हाँ जी, 30,000।
कितने आ रहे हैं?
अरे खूब आते हैं, जेब भरी रहती है। देखो अभी भी जेब भर रही है माशाल्लाह। पैसे ही पैसे हैं यूट्यूब में, आप भी काम करो। आप कहाँ से आए हैं? गुड़गांव से। नाम बताइए।
डॉक्टर रोहतास कटारिया।
अच्छा
खान से।
अच्छा।
क्या हाल है?
साजिद भाई हमारे बहुत पुराने सीनियर हैं और मिलके जो है बहुत खुशी हुई है। आजकल ये मसरूफ़ ज़्यादा रहते हैं दूसरे कामों में। हाँ, डॉक्टर नासिर खान 99 पर आप विज़िट करके देख सकते हैं। सही चलेगा। हमारे डॉक्टर जाहिद साहब हैं जिनके बारे में हमने बात की थी, कैब में बैठे बैठे बहुत गुफ्तगू की है आपने। ये वेदांता का जो है आपको अंदर का दिखा रहा हूँ मैं, यहाँ का कुछ चीज़ें दिखाऊंगा। अभी जो है खाने पीने का भी हम लोगों का हुआ है और डॉक्टर तेहरान जी को कहीं जाना था इसलिए जो है वो जा चुके हैं। आपके क्या नाम है?
डॉक्टर अर्जुमन फिरोज।
कहाँ से आई हैं आप?
मैं
MSN कुंज से आई हूँ और आई एम वर्किंग एज RMO इन सूर्य किरण हॉस्पिटल नजफगढ़।
आप?
Myself Dr. Sitili, I am from Delhi and I am working as an
वेरी गुड। देखिए NCR से पूरे डॉक्टर्स की यहाँ टीम आई हुई है मेदांता हॉस्पिटल गुड़गांव में। देखो ये बाहर का नज़ारा है, गुड़गांव की बड़ी बड़ी बिल्डिंगें हैं। ये मेदांता हॉस्पिटल वेलकम्स डेलीगेट्स।
So that's why I was asking you if any of you or your family member has experienced stroke, and it becomes very difficult. If everything is going okay, you are playing with them, you are talking to them, and suddenly they get an attack. So stroke is basically when blood vessels to the brain gets occluded or burst, like a bleeding. So we call it fast, face, arm, speech and time. So that is where, as doctors, it's our duty to create this awareness that what we can do if this suddenly happens. It's almost similar to heart attack, that the artery gets blocked and you need to open this artery immediately if you want to save the heart. The same thing which we need to do for brain. That if this happens, we need to go to the hospital quickly, urgently, so that we can get this treatment very fast. So, you will wonder why I am showing you all these pictures. So, typically, the stroke risk, जो सबसे बोलते हैं diabetes, blood pressure, high cholesterol level, lack of exercise, genetic factors, those are there. And they will always be there. If somebody is having a heart problem, very high risk for having a stroke because they can throw clot into the brain. But these are some of the new risk factors which we have seen recently, and so many doctors are coming here. That's so surprising, especially the younger generation. So, you will not believe, in 2023 alone, I have seen 5 patients who have gone to cyber for a party. And while dancing, they give this sudden jerk to the neck. There are so many steps these days, and that causes dissection of the artery, and that causes stroke. Or ladies are going, sorry to use the word ladies, but they are most commonly they are going for spas and all, and these spa masseuse, they press on their arteries so bad that the arteries get blocked, and that causes stroke. For our old age free barber massage is not so free. That also is a risk. So these are some of the new generation risk factors which have come. 20 years back, nobody was dancing in the pub so much, getting drunk, and we were not seeing that. But now these patients, these young patients, are also coming. And it's our duty to educate these youngsters that be careful, it can just change or alter their life altogether. So what to do? Let's say we watch somebody who is not able to lift his arm, he is not able to talk properly, or his mouth getting deviated. You realize the patient is having a stroke. What will you do? So we start thinking, okay, I just told you it's like a heart attack. So it's like a brain attack. We can give some sort of a blood thinners. Then we give aspirin or any other blood thinners which are there. But the brain is not so simple. Because in brain, this stroke can also be due to brain hemorrhage. If you give these blood thinners, it can be harmful to these patients. So we have to be careful that we should only give the treatment once we have done a CT scan to make sure whether it's a bleed or whether it's a occluded artery. The other thing which comes to our mind is, obviously we are all trained doctors, so we check the blood pressure, we check the pulse, and if the blood pressure is too high, so if the blood pressure is too high, we want to reduce the blood pressure or lower the blood pressure. In a stroke, until unless it's very high, it's like 220, 120, that high, then you should reduce it to 185, 100 sort of a thing. But if it is 190, 100, 190, 90, you should not reduce, because brain is trying to compensate. One artery is blocked, the brain is trying to compensate. So be cautious in suddenly lowering the blood pressure. अब सवाल ये उठता है कि बहुत सारे डॉक्टर्स मुझसे पूछते हैं, ना दवाई दे सकते हैं, ना ब्लड प्रेशर कर सकते हैं, तो पेशेंट तो मुझे मारेगा कि मैं यहाँ आपके पास लाया था, आपने तो कहा वहाँ चले जाओ जी, सीटी स्कैन कराओ, इतने में कुछ हो गया तो लड़ाई हो जाएगी. So, because these all are American guidelines, you know, in Indian setup it becomes slightly difficult. So, what I typically tell them is, we can start on some cholesterol lowering medication, statins, so patient doesn't feel that I am not getting a treatment. If the blood pressure is too high, reduce it slightly. अगर आप एक गोली दे भी देंगे, जब तक ओरल उसका इफेक्ट आएगा, खत्म होगा, तब तक तो उसका स्कैन वगैरह हम कर लेंगे. So we have to use it judiciously to safeguard ourselves, but also to ensure that we do not harm our patient. So चलते हैं, हॉस्पिटल चलते हैं. आपने कहा सीटी स्कैन करना है, हमें ये करना है. Yes sir, बताइए. So labetalol is the drug of choice. Reduce the blood pressure. Let's say the blood pressure is 220 by 120. The labetalol is the drug of choice. NTG should be avoided because NTG will cause a lot of vasodilatation and chances of bleed will increase. No diuretics. No diuretics. Labetalol is the drug of choice to reduce the blood pressure in acute stroke patients. It's very safe thing. सर वो तो फिर इंजेक्टेबल ही करना पड़ेगा अगर ओरल नहीं करना. So now in our own country we have unique problems. Patient doesn't want to come to any doctor. He wants to go to a Baba, Oja, and it's not true for uneducated people. It's true for highly educated people also. Like उनका ये मानना होता है कि डॉक्टर तो पता नहीं खा जाएगा हमें, तो पहले इससे छुआ के आ जाते हैं, इससे ठीक हो जाएगा. And what TIA होते हैं, transient ischemic attack, so 50% of the patients will actually improve by them. So that leads to this myth कि these are the actual stroke doctors rather than us. Even if somebody wants to come, as Dr. Trehan was saying, traffic is so bad these days that it's difficult for these patients to reach on time. So, and I'm going to explain to you how do we choose hospitals also. It's not like you can go to any hospital. So these are some of the things. So we have been talking about creating green corridors for ambulance. Actually कुछ तो progress हुई है, ambulance को लोग रास्ता देने लगे हैं, fine होने लग गया है कि अगर आप ambulance को रास्ता नहीं देते हैं. तो a little bit changes have started happening. One of the new concept which is coming is, why don't we install a CT scanner in an ambulance only? So rather than patient coming to the hospital, then we doing a scan and then giving medication, why not install a CT scanner in the ambulance, send the CT to the patient and see if it works. So again, it works well in European countries where there is no traffic, less number of patients. In India, these are expensive. You can probably get one ambulance, but दिन भर में 5 कॉल आएंगे, आप कहाँ उसको भेज पाएंगे, तो थोड़ा restriction है. Or we can do an air ambulance so that we can quickly ship these patients. I don't think in my lifetime I'm going to see that in India, but who knows. So दूसरा ये है कि which hospital to go. Not all hospitals are safe. So we need to decide whether it's a stroke ready hospital. Stroke ready hospital का meaning है hospital should actually have a CT scanner and way to give thrombolytic medication. So if these two facilities are there, it's a stroke ready hospital. Comprehensive stroke center is where you may find an interventionist who can open up these arteries if your medication is not effective, or if we need to put a stent. So comprehensive stroke center is the highest level of center. Now you need to decide. We all are sitting in Delhi NCR, so we all have access to comprehensive stroke centers or tertiary stroke centers. But somebody who is, let's say, in not so developed part of the country, and if the comprehensive stroke center is 2 hours away and the stroke ready hospital is 20 minutes away, they should go first to the stroke ready hospital so that they can do the CT scan, they can do the thrombolysis if required, and if then the patient is not improving, then he can be transferred to a comprehensive stroke center. But if the comprehensive stroke center and primary stroke care center are almost we can reach at the same time. Let's say primary stroke center we can reach in 20 minutes and comprehensive stroke center we can reach in 40 minutes. We should still try to reach to a comprehensive stroke center, because then the patient's management and outcome will be entirely different. So, ये क्या मैं example है, so this patient, I'm just going to hide the name of the patient. So they went to one of the fancy hospitals of Gurgaon, and this is how we work on a WhatsApp. So I cannot be in the hospital 24/7. So one of the team members, they will look at the scan, look at the patient, keep updating everybody in the team, and that in that hospital, because this is a teamwork, no one doctor can do. So that doctor was on a leave, so there was nobody to do this treatment. So the patient got transferred here, and these pictures actually show you, these are the brain arteries. So this is the internal carotid artery, anterior cerebral artery, this is the middle cerebral artery. And here it is blocked. We can see the clot. There is no blood flow in this region. And once we have opened up this artery, we can see the blood is going smoothly to the brain. All this happened within a fraction of 10 to 15 minutes by the time the patient reached there. And she is immediately
एक-एक करके दोनों हाथ उठाइए, दूसरा भी
she was not able to lift her left hand when she came.
उठाइए ऊपर, ऊपर उठाइए, वेरी
Because we have removed the clot,
ठीक
the brain
है,
is
वैसे ही
not
एक-एक
damaged.
करके दोनों टांगे उठाइए, पहले राइट, चलो लेफ्ट, राइट उठाओ, ठीक है.
So this is what say, but not everybody can be so lucky that they went to a wrong hospital and then can be shifted to a right hospital. Now the next question comes, when should we, what should we say is the golden hour? When can we do these treatments? So for IV thrombolysis, whether we are using Actylize or tenecteplase, the golden hour window, anybody knows the answer? Perfect, sir. So 4.5 hours. So from time of 4.5 hours, we can thrombolize these patients. And there are some contraindications that the patient should not have a major surgery, patient should not be having a high INR of more than 1.7, and some relatively contraindications are there. But more or less, if there is a patient of stroke within 4.5 hours, you take a history and there is no major contraindication, we can do the thrombolysis. Now the difficult question, because this is what I do, I don't know if you know what I do. So what's the time where we can remove these clots by stent? It's not 4.5 hours now. So the right answer is 24 hours. So we can treat these patients up to 24 hours. So the window is there actually now, where we can treat many more of these patients. And mechanical thrombectomy, or as we like to call it, MT, is becoming the treatment of choice for these stroke patients. So, and this is what we call number needed to treat. If I ask anybody of you, and in fact not even you, as the general public, if I ask what to do if somebody is having a heart attack, you will say angioplasty kara lete hain. That number needed to treat for angioplasty is 19. So that if you do 19 patients, then one patient will benefit. The number needed to treat for acute stroke is actually 2.4. So such is the high impact of this treatment on patient's life that we can save so many more patients' life. You can see on the green number of patients just with thrombolysis, and this is number of patients we can save if we do mechanical thrombectomy also if required. So this has become a major thing, and randomized, there are 9 or 10 now randomized controlled trials which have shown one after the other that this is the treatment which we should offer, and within 24 hours, these are the guidelines. These are American Heart Association guidelines, American Stroke Association guidelines, which says that we should do that. But we should not say that don't give thrombolysis. So medication is also required, stent is also required, whatever we can do to do this. This is some imaging which we do on our CT scanners. We try to see how much of the brain is actually damaged. So I'll show you an example. So this is an 85-year-old man. He has a blockage of left common carotid artery. So we look at these scans. Here the damage is not there, and all this red which we are seeing is the area which we can save if we open up the artery. So we gather all this information in 5 to 10 minutes, and I'll show you this patient this is when he came. I don't know if the video is going to play.
नाम बताइए भाजी, नाम बताओ, नाम नाम इधर देखो,
तो कंफ्यूज
इधर देखो,
क्योंकि लेफ्ट साइड गया है,
इधर देखो भाजी, इधर जी दिखाओ, मेरी तरफ देखो,
कमांड्स इधर फॉलो कर रहे हैं,
इधर देखो भाजी, इधर इधर,
तो ये इमरजेंसी
इधर देखो,
से बनाए हुए
पैर उठाओ, पैर उठाओ, पैर उठाओ भाजी, इधर देखो, इधर मेरी तरफ.
So we go with these stents, and this is the stent, this is the artery which is blocked. So we can see there is a big clot. Again, nothing is going inside, and we can pull this clots out using the stent. This is how it looks like. And the stent is full of clots. So we have taken out the whole clot from it, and now the artery is flowing. The brain is receiving the blood supply. And what impact it makes on patient is.
नाम बताओ. नाम. हाँ. सर. इधर देखो मेरी तरफ. हाथ उठाओ अपना. सीधा हाथ उठाओ. सीधा हाथ ऊपर ऊपर.
Again, like dramatic change. In a span of half an hour. Because we could open up this artery. And this patient who will be for the remaining of his life on a bed.
हाँ. दोनों पैर ऊपर.
And now
सीधा पैर ऊपर उठाओ.
doing his normal work. This is a 4 years old case.
दांत दिखाओ अपना. दांत दिखाओ.
Comes to the OPD walking. ऐसे दुआ देके जाते हैं बाबा जी आके आपने जिंदगी बचाया.
नाम.
I'll show you another case. So very interesting case.
जीभ दिखा. दांत दिखा अपने. तो दांत ऐसे ही. जीभ अंदर कर ले.
She was a heart.
दांत दिखा. दांत.
वो हार्ट में.
अच्छा नाम बताओ अपना.
लेफ्ट साइड थोड़ा कम है.
अच्छा जीभ ऐसे दांत ऐसे कर अम्मा. जांच ही. हाँ ठीक है. अच्छा हाथ उठा. हाथ उठा. ये वाला नहीं, ये वाला हाथ उठा. हाँ ऊपर कर अम्मा. हाथ ऊपर कर. उठा. अच्छा ठीक है. अच्छा
तो हमने इनको थ्रोम्बोलिसिस दिया. थ्रोम्बोलिसिस देते ही she became worse. We thought she had a seizure or maybe she has bled because we are giving thrombolytic medication. And this is the video now when she was worsened.
Mataji.
So now she is not obeying anything. She is not following commands. She is just in a restless state, difficulty in breathing also. Now suddenly she is starting moving a little bit of the left side, but right side she is not moving at all. So what has happened? This patient got a stroke on both sides. Because of the heart clot, by the time we saw her between the first scan and now the second scan, we can see the arteries are blocked on the right side also and left side also. We can see this is the red scan where we can identify that if we open up these arteries, we can save this brain. So again we went in, we opened up both sides, right and left, and CT scan was okay the next day. This is after 3 months from her home. So she has gone back to her normal work. So she's still little bit weak, but still doing a lot of work at her home and almost living a normal life. So this is the power of the stroke treatment which we can do today. And this is some of the studies and trials which have come up that even when these patients are losing brain, we should try to treat them with IV thrombolysis medication as well as stent medication. And these are again like a lot of trials and studies. I'll not bore you with that we can reduce and help these patients in their outcome. But the most important thing is that it's not just taking this clot out which brings this patient back to life. And this is where I think as a community we have to be there together. Because see, these patients need drugs so that they do not get stroke again. They need rehabilitation. Many of these patients undergo depression. They lose their self-confidence. They need to change their lifestyle. They need to stop smoking. They need to start exercising. They need control of their blood pressure, diabetes, cholesterol. Cholesterol has become a big thing, that it has to be less than 70 in these patients, the lipid profile. Otherwise, there is a high risk of stroke. So all of this has to be done by a primary care physician, because stroke specialist or acute medicine person will do their job in emergency and in the hospital. That is probably 20% of the thing. But 80% whether this patient will go back to the normal life, whether he will start functioning in the way, whether it's meaningful for the society, is the role of primary stroke care physician. And that's where I think as a community we have to evolve. Now, a little bit about prevention. It's cricket season. So just a funny video to show how if we sometimes do not decide, sometimes in a confusion, how it can get dangerous for us. So, sometimes people just keep deciding on where to go. So many a times what we find is these patients are having a blockage, and when we do Doppler or CT angiographies, we are able to find that okay, this patient is having 80%, 90% blockage. So like this patient, this is one of our old patients, as you can see, from 2016. We told them that they should get a bypass or a stent. They refused. And 3 months later, this patient was on a trip to Vaishno Devi, and he got a major stroke. He was in a hilly terrain. He couldn't be brought here or to the major hospital immediately. By the time they did everything, the whole brain was damaged. So in the MRI, whatever we are seeing, why it is damaged. So one half of the brain was completely gone. So God gave him a chance. It was diagnosed, but they couldn't make up their mind. And that's where, like, if we do find 70-80% blockage on routine health checkups, we should not ignore it. It's very important to do that. Now, a general knowledge thing. How many of you recognize any of them? Joe Biden we recognize. Nobody recognizes Sharon Stone? She is in the center. And this is from Game of Thrones, Khaleesi. I don't know if anybody of you have seen Game of Thrones. So what's common among all three? Why I'm showing you this picture on in a hospital? Yes. So all three of them got a brain hemorrhage from an aneurysm. And why I'm showing you this picture? Because they got a successful treatment, and today if he's running, whether you agree whether he's running nicely or not, he's still running a major country. And so the other side of the brain stroke is hemorrhagic stroke, where we used to do these open craniotomies and surgical clippings, and patient will be left with a major scar. And similar to these stents which we are using to treat stroke, we can treat them by coiling also. So we go again through the leg. So as an interventionist, we go inside these aneurysms and seal this by using platinum coils. So let me show you this animation so you may get an idea of what we do here. So there are many techniques to it. Simple coiling, we do balloon coiling. So there is no audio. So somewhere in the brain, we can get this swelling, and as we come from the leg, we can bring a tube inside, and this is a balloon to protect so that whatever we are putting, it stays inside the swelling in the aneurysm and doesn't come out in the main artery. And these are the platinum coils which we can put through this micro catheters to seal these aneurysms. So it's a very novel way. I still say novel, though it's like almost 30 years old now. And it's a non-invasive or minimally invasive way to treat this brain hemorrhage patients. And once you are in a satisfactory position, we detach these coils, and these takes like we need to put 4, 5, 6 coils depending on the size of the aneurysm, and then we can seal this aneurysm completely. So this is with the help of a balloon. Sometimes we need to do a stent also, so we can keep coiling till the aneurysm is completely secure. This is how it looks like in real life, not in animation. So this is again the brain artery. We can see a big swelling here. This is the aneurysm. We do an angiography to understand where the aneurysm is, where the artery is. And this is a tube through which we are placing the platinum coils. And this is at the end of procedure. The aneurysm is completely gone and the arteries are flowing. So these are some of the minimally invasive ways to treat this. And now, as I was saying, there are numerous stents which are called flow diverters, in which we don't even have to go inside the aneurysm. We can treat them from outside. So again, a small animation to show you. These are all company-made animations. So there are numerous companies which make all this. So as you can see on your screen, they look like stent, but the pore size is very less. And everything we do is over a wire and a catheter. So here you can see we are not going inside the aneurysm. The aneurysm is here. We are staying outside the aneurysm and we are just deploying this fine mesh called flow diverter so that the blood does not enter the aneurysm as fast as it was entering before. And this slowing will cause this aneurysm to shrink. So over a period of time, this aneurysm will shrink, and when we do this angiography, the aneurysm is gone. So the advantage is the risk is less. Since you are not going inside the aneurysm, you have a less chance of rupturing this aneurysm and perforating it. So see these big aneurysms for which 15 years back actually there was no treatment. When I started doing my training, when these aneurysms used to come to us, we used to tell the patient, artery बंद करना पड़ेगा, कोई रास्ता नहीं है अभी, फिर देखेंगे. And now we can place these flow diverters and so look at this. This was such a bad disease. We have placed a flow diverter and the whole artery has become like a new. So these all technical revolutions have changed the way we do treatment. And few of the snippets which I have seen in my life is we see a patient who has got a brain hemorrhage. We do a CT angiography or MR angiography to see if there is any problem. But most often what happens is CT angiogram and MR angiogram can miss this. So this is one of the patients in which we did a CT angio and MR angio, every report was normal. But when we did a DSA, we could find that there is an aneurysm which was hidden behind the branch. And if we would not have treated it, it would have rebled and the patient could have died. Again, the second thing is these patients will have fluctuating blood pressure. Somebody has a brain hemorrhage, they will have a fluctuating blood pressure. But if we wait for everything to stabilize, these aneurysms can rebleed, re-rupture, and chances of death is very high. So stabilize the patient, but do not take a lot of time because this can prove catastrophic for these patients. Again, some of the new technologies of putting a flow diverter inside the aneurysm now. So these are new technologies which are coming up. But at Medanta, we are like tertiary center. I have done now more than 3,000 aneurysms. We do the maximum number of stroke treatment in the country. And we are very proud of what we do here. And if there is time, I just like to show you one video of how we approach these patients. I'm just skipping few of the things to show you this video. So this was made by one of our fellows last year. So this summarizes how we approach these patients fast. I'm very proud of our stroke program, which kicks in as soon as the patient arrives at the emergency door and is wheeled into our triage. Patient is quickly shifted for a CT scan once the stroke code is declared. And that's where I want to highlight the importance of stroke code. We do all get called simultaneously and not one after the other. We know that there is a stroke and everybody in the team gets notified at the same time, and we converge in the CT scan room as the scan is being done, and there, since we all are there, we are able to take the decisions together, faster, and for the betterment of the patient. The most crucial point in Indian healthcare system is about financial power. Whether we have to give thrombolysis or to do mechanical thrombectomy, how do we do the financial clearance? So our hospital is very supportive, and we do not need financial clearance to start the procedure as long as the patient agrees that they will pay it up in the future. They just sign a disclosure and we move on. So it's relatively easy and straightforward, and it helps the patients that way.
In most of the cases, PTINR, platelet, we don't waste time in doing those investigations. We simply do blood sugar levels. We put in cannula in both the arms, and we shift the patient in CT scan without wasting time. And while CT is being done, we thrombolyze the patient on CT table, and over a period of time, we have reduced our stroke to natal time to less than 20 minutes.
Once we have decided that the patient is having a major mismatch on CT perfusion maps and there is a major vessel occlusion, we concur among our team, discuss with the family, and a decision for mechanical thrombectomy is taken and the patient is being shifted. Now you can see that the patient is being freed from CT scan to DSLR. We have an emergency at ground floor, CT scan is right adjacent to it, the DSLR is on the third floor. And that's why when we raise the stroke code, it also goes to the lift man, so he keeps the lift ready. The cath lab door is open. Sometimes when it's middle of the night, it might be locked. So the security team also get to know that there's a stroke coming in, and the patient can be quickly wheeled into the DSLR as fast as possible. Once inside the lab, we prepare the patient. We can discard Foley's if it's not already put. We do not waste time to put Foley's catheter in. We just secured a basic IV line access, which is usually there from the CT scan. Quickly drape the patient, and we work in parallel. One of the team members, you can see, is trying to do a puncture